Hello again to all of you. Thanks to dear Dr. Christie for having me here, and thanks for the legendary warm Arvind hospitality. So I'm Radhika from Sankara Nethralaya, Chennai, and we have all had situations where we have come to a stalemate with a corneal ulcer, either because it is stubborn and not moving in any direction and it is indolent, or it is progressing in terms of increase in the infiltration or melt, or both. There are multiple reasons that are possible for this kind of a situation. Either you can be dealing with an organism which is very virulent, or you can be dealing with an organism which is atypical, which you have not thought of. The infection may be located in the cornea where it is difficult for the drugs to penetrate, or there could be a mixed etiology. There could be some triggers like dry eye or exposure or foreign body, or the infection could be of mixed etiology, a polymicrobial infection where you have not unraveled all the culprits. The patient may not be complying with the treatment very well, or the bugs are very smart that they come up with resistance, or very rarely the infection is not healing well because it is not an infection at all. So these are so variable that it is not possible to fit these into an algorithmic approach of management. So I am going to share with you, representing these, some real life case situations, most of which we have published. So take for example, this fungal infection which was set up because of a thorn injury. So it is a small to medium kind of infiltrate, but if you take a look at the slit picture, you can see that it is involving the full thickness of the cornea and producing an endothelial involvement also. So the penetration of the antifungal agents was not enough to bring about a resolution in this case. So this is a textbook case where intrastromal injection can be used. Why? Because you have a deep infection where the drugs won't penetrate, but for intrastromal injection, one most important criteria is that the surrounding cornea should be reasonably normal. Because if you have a large ulcer and you go and inject in the margins of the ulcer, not only you will not have benefit of the injection, you can cause perforation also. So we gave barrage injections of intrastromal voriconazole along with continuing the topical antifungal agents, and you can see that the ulcer is beginning to scar nicely with consolidation of the hypopyon. Contrasted with this infection, we are all familiar with this kind of presentation of demititious fungal keratitis. It looks like, two small little things on the cornea, very innocuous. But sometimes it can be very difficult to treat because of 2 points. One is that the plaque is easily scrapable. You can remove off the plaque. So you think that you can just, debulk it on slit lamp. But 2 things. One is the underlying cornea usually is not thinned out, but it can be very spongy. So during plaque removal, even though the corneal thickness is normal, the spongy nature can lead to microperforations. The second point to be remembered is after the scraping of the plaque also, sometimes the infection can be very indolent. This was caused by Cladorhinum species, and we had to put the patient through topical antifungal agents for many months after scraping of the plaque before you can see resolution, which is happening in the second picture. So a word about other types of fungal infections which can mimic other infections. I have not put pictures over here because Dr. Srinivasan has shown very nice ones. So any fungus which grows very quickly within 2 days time, or any fungus which is very symptomatic, is likely to be Pythium keratitis, because we all know about the tentacles, the reticulate nature of the infiltrate, the furrowing, everything. But then the 2 observations that I have made are that it may or may not be proven in literature, grows very fast, and because it has more inflammation than fungal keratitis, the Pythium keratitis produces a lot of symptoms. Likewise, any fungal infection which has lasted for months together, usually fungal keratitis, either it resolves or it progresses. If both don't happen, it is lasting for many months, then do suspect microsporidial stromal keratitis. So regarding bacterial keratitis, when you don't have a satisfactory outcome, I think we made these points in the discussion already, that vancomycin has got a strong, a mechanism of action in a small subgroup of patients, and you have to use it carefully for these organisms. The older antibiotics can be revived like chloramphenicol or gentamicin, and the gray baby syndrome or the immune suppression is more common with systemic chloramphenicol. When you have Topical application, like Dr. Srinivasan pointed out, one anecdotal report, but you can use it safely. When you have multiple drug resistance, you can use linezolid. And it's not only the organism. Let's not be, horse with blinkers and focus only on the organism. There could be other foci. For example, that inset picture shows a patient in whom there was recurrent, flictin. Flictin is not infective in that sense, but it's the infective antigen that produces the inflammation. And every time he would recur. And then you take a look at the picture on the right, then we figured out that he's got a lot of staphylococcal pustules on the scalp. He was treated with a combination of tazobactam by the dermatologist. The flictin never came up again. So look for septic focus in the ear, in the nose, on the scalp, whenever a bacterial keratitis keeps coming back again and again. So these are some, beautiful pictures where I have shown some typical presentations of atypical infection. You have the mycobacteria, which is affecting the wound very characteristically and has that necklace-like appearance. And you have that infectious crystalline keratopathy, where you have needles in the cornea, not much inflammation because it is, nicely cozy over there because of the steroids being used for the keratoplasty. And then you have the nice wreath pattern appearance of the nocardial infection. However, these don't present like this always. So like Rakshit pointed out in the morning, a high index of suspicion is required. Otherwise, we may be treating in the wrong lines and thinking that the infection is not healing. So when you have a non-resolving microbial keratitis, don't hesitate to rescrape. Okay, it's nothing wrong in rescraping, but we should not make the same mistakes as we made in the primary scraping. So better to give a drug holiday. This has got a few additional, components to it. The legality of it and the psychology of the patient needs to be addressed before we stop the medication in an active infection. If you see picture B, the infection has got three components. Where it is circled, it has already started scarring. So if you scrape there, you're only going to get bits of fibrous tissue. In the center, you can see liquefaction necrosis. If you scrape there, you will get only pus and neutrophils. See where the arrow is pointing, there is the leading edge of the ulcer for you to scrape to get any kind of microbiological result. And also, especially in bacterial infections, after you scrape like in picture A, you have to document the size of the epithelial defect. At least in bacterial keratitis, healing of the epithelial defect is imperative to the healing of the infection itself. If you take a look at picture C, it looks like this infection is nicely scarred and, white and everything. But take a closer look, the eye is still inflamed and injected. So some of the very virulent infections like nocardia, stromal microsporidiosis can present with whitish infiltrates. So white is not always quiet in the context of microbial keratitis. So over a period of last few years, when you have a slightly different clinical situation or stubborn infections, I have tried to gainfully employ the usage of anterior segment OCT. So I'll show you with a couple of examples how they have helped in my diagnosis and management. This is a patient who had a coir injury, coconut coir injury, and he came with a small to medium size corneal ulcer. We scraped and we found Mycobacterium abscessus, which is an atypical mycobacterial keratitis. So again, a fact that I want to point out is we started him on amikacin and then he developed the typical cracked windshield appearance. So you don't see this appearance in every NTM, but then don't expect NTM to present with this kind of appearance. The ones in whom the cracked windshield develops, it develops after the starting of the treatment. I don't know whether others have this experience. So you watch out carefully for the clinical features as the disease is evolving. So we continued him on topical amikacin and he was stalemate. He was not progressing anywhere. Then we did the ASOCT where we found that in contrast to the smallish kind of infiltrate where the blue arrow is pointing, a large endothelial exudate was virtually extending till the anterior lens capsule. So the infection was much more than what was let on the slit lamp because the patient was uncooperative, cornea was edematous, and this bang behind the infiltrate, we could not make out the extent. So now we threw in oral clarithromycin in the mix after the due precautions, and then you can see that the infection responded and the ASOCT shows that the endoexudate is resolving very nicely. So here is where it was a smaller ulcer, but it actually turned out to be more invasive. Here is the reverse. After the infection healed, somebody referred this patient from outside for an urgent patch graft for the gutter in the center. So here I don't know about the epithelialization because even if you put fluorescein, it will cause only pooling. So then we did the ASOCT. You can see the pooling of the mucky tears in the center. But I want to draw your attention to the line of epithelium. You can see that the epithelium over the cornea is continuous in that U-shaped gutter. So which means that this infection has epithelialized completely. So we deferred an urgent patch graft in favor of a more definitive later procedure. So infection and immunity can coexist is what we've seen all of morning. And a typical case example is mycobacterial sclerokeratouveitis. The antigen comes from the mycobacteria, and the multiple pus points in the sclera and the uveitis are testament that inflammation is also happening. So these are the kind of cases where you need to use both the antimicrobial as well as the steroid. I'm not going to elaborate because we just had a discussion. But my take on Pseudomonas keratitis, you have this typical ring ulcer, scraped, Pseudomonas was isolated. We started amikacin. And in the second picture, you can see that some response to amikacin is there. The scarring has started, but still the eye is inflamed. I don't wait for the 48-hour window alone as per SCUT. I wait a little longer till I see this kind of early scarring. And then I started topical steroid. In the last picture, you can see that the resolution is nice and the inflammation is less. So in Pseudomonas, at one point of time, steroid was taboo, but in a structured manner, it can be employed in the treatment. There is no better example, as Dr. Gabriel pointed out, of infection and immunity coexisting as with stromal necrotic HSV keratitis. So you can see the microbiological proven HSV stromal keratitis over there, but you can see the immune ring as well, which is showing, both components of the problem. Here, you have to use therapeutic dose of antiviral agent and therapeutic dose of topical steroid. If you skimp on one or the other, you will not get the resolution which you are seeing in the second picture. So in HSV disease, normally you don't want to do ketoplasty. It's a poor indication for ketoplasty, but sometimes we have to if it's a single-eyed patient or the patient is insisting or large scar or something. So this is the typical appearance of a HSV dendrite, and our bugbear is that the dendrite will recur in the graft. So this is a post-HSV graft where in the first few days we saw this epithelial disturbance. Is it a recurrence of the dendrite? It takes as much time as the corneal nerves to grow back, to bring the HSV back into the graft. So anything that comes on in the immediate postoperative period, anything which is not staining very typically of HSV, is likely to be just a postoperative epithelial defect. The graft is just trying to re-epithelialize. So if we put topical acyclovir over here, we are only going to increase the epithelial toxicity. Contrast this with this. Here, this lesion came on a few months after the graft. So it's got that typical geographic shape. It is straddling the graft host junction and it is staining with rose bengal. So you have every box checked to tell you that this is a HSV recurrence. Here you have to pump in, systemic antiviral therapy. And a word to note over here is that HSV is a recurrent disease, but it has its own discipline. It is usually respecting its own compartment. When you have epithelial disease in a normal cornea, it usually does not go on to stromal necrotic keratitis. But in a graft situation, either because of the chronic topical corticosteroid use or any other reason, when you have epithelial disease and you don't check it in time, it can progress to stromal necrotic keratitis and become difficult to treat. So that's the difference between progression to stromal necrotic in a normal eye and in a post-graft eye. So this is an interesting patient where at the first glance you see multiple infiltrates. There's a lucid interval and the infiltrates are a little whitish, not very angry, and they're epithelialized. So you can, make a diagnosis of staph immune disease or any other immunological marginal keratitis. But take a closer look. You see that the eye is inflamed and also congested. You can also see a blob of discharge over there. Normally in immune infiltrates, especially staph blepharitis, you don't see this kind of picture. So this is herpetic blepharokeratoconjunctivitis. What are the differences? When you have a staph marginal, you have a dry blepharitis, whereas in HSV primary disease, you have an inflamed blepharitis with congestion. In staph, the peripheral immune infiltrate is quite mild, whereas in HSV, you don't have the lucid interval and it is a vicious infiltrate. So staph is an immunological disease and you can give topical steroids. HSV blepharokeratoconjunctivitis is a primary form of HSV disease. If you give the steroid, it is going to cause propagation of the disease. Here again, the treatment is with dedicated antiviral agents. Hence, you should know the difference between the two. So if infective and immune can coexist, how do we know, which is more active for us to start the treatment? You can't find out always, but there may be some subtle clues. Suppose you have a defect like this with a little yellowish base like this. If the epithelial defect came first and then the infiltrate happened, it is likely to be an infection. That's how the infection gets in. However, if you see granularity of the stroma, if you happen to see the patient in an early stage and then the epithelium broke down on top of it, then it is likely to be of immune etiology. This is if you see the patient early. If you see the patient a little later, then you take a look at how much is the infiltration, how much is the melting. Here you see a bad ring infiltrate due to Pseudomonas keratitis. It is threatening to involve the whole of the cornea with a significant hypopyon, greenish discharge, all the works. But the cornea is just about started melting. And by contrast, take a look at this Murren's ulcer, which has destroyed almost 1/3 of the cornea. And at the same time, the infiltration is very less over here. So more of infiltration indicates infection and more of melting indicates immune disease. But of course, you can have exceptions to this rule as well. So when you have bilateral lesions, when you have telltale marks of previous disease, when you have multiple lesions like these in both the eyes, then it's likely that the immune component is definitely there. So infection sometimes may not heal, not because the drug is not correct or the patient is not cooperating, but there are some triggers which are preventing the healing. Take, for example, this is a patient in whom the bacterial keratitis was treated elsewhere. The treating physician did not give steroid or cyclosporin to combat the inflammation. Rather, they gave NSAIDs. So NSAID, in the presence of an open epithelial defect, the infection is healed, but you have a burrowing crater threatening perforation over here. So, and now you have lagophthalmos here where the lid is not closing. So the infection is struggling to re-epithelize itself because of poor blink and exposure. Here is a patient who underwent a bedside tasseraphy. Instead of helping the patient, the pokey bolsters and the sutures are actually becoming counterproductive to treating the problem. So all of us are familiar with this situation where the HSV has long left the cornea. It leaves the cornea neurotrophic. So there is no active infiltrate. You have rounded margins with a grayish base. So even the fellows can make a diagnosis that this is a neurotrophic keratitis. But that's not what I'm trying to show you. I want to draw your attention to the second picture where despite multiple treatments like tasseraphies and AMTs and punctal occlusion when they did not heal, we employed a unique approach of treating this patient with PROS contact lenses or scleral contact lens. Scleral contact lens in this case was not to improve the vision of the patient, rather to help in the re-epithelization. Can be done in select cases. It has to be an in-office approach because the patient is new to this treatment. Removing itself, they can hurt the cornea more. So trained optometrists, when they do this and monitor the patient on a daily basis, it can heal the epithelial defect in a so-called non-healing, neurotrophic keratitis. So, well, this infection is not healing. Why? Because it has already healed. It's a favorite slide of mine which shows a healed perforation where you have the components of the fibrosis of the inflammatory exudate enmeshed underneath by the iris tissue and layered on top with the healing epithelium. So this is a stage of pseudocornea. It's healed, so no further treatment is required. Only you have to take care that there is no injury from outside and there is no IOP rise from inside. If these two are taken care of, then this will slowly progress to become an adherent leukoma. Well, sometimes to conclude, an infection doesn't heal because, well, it is not an infection at all. I'll conclude with a couple of very interesting case examples. This is a patient who you see on top who was on treatment for a long while for HSV keratouveitis because of that star-studded capes in the cornea. But take a look at the picture below. You can see a flocculent cataract. Now, which HSV produces flocculent cataract? So we dug a little deeper and the history showed us that there was a vague history of, trauma. And where the pink arrow is pointing, you can see a small dehiscence in the lens capsule. So it was a leaky lens that was producing the inflammation over here. Why should we know the difference? Because in HSV, we need to quieten the eye before doing the cataract surgery. But here the lens is the culprit. Unless and until you get it out, anti-inflammatory is not going to be useful at all. So here is another patient who had a flap tear and was referred to as saying that he has developed infection. It was a young boy and you can see that yellowish appearing flap with hypopyon. So now the lessons from displaced LASIK flap that we have learned have taught us that Whenever a flap is not opposed to the bed, its nutrition suffers, it undergoes necrosis. So here that along with the young age of the patient has caused a lot of inflammatory outpouring, which was the hypopion. So all we did was we took him up, debrided the epithelium, washed the interface, put the flap back and started a little bit of steroid, and without a drop of antibiotic, you can see that the infection has healed nicely in the second picture. So this is yet another patient who was referred to us with diagnosis of infection after CXL. Rakshit pointed this out in the morning that when you have multiple infiltrates, and some more points I would like to add to the diagnosis are when they are whitish, when the epithelium is intact over these, and when the eye is asymptomatic. When you have a combination of all these four factors, then it's likely that you're dealing with allergy or immune response rather than an infection itself. And you can see the healing with anti-inflammatory treatment happening in the second picture. So it's not as though CXL always will cause only a dye reaction. You can have these kind of serious infections also rarely with CXL. Why? It happens in very small number of cases. It can happen quite early. The triggers are usually the bandage contact lens and or the topical steroid. But in CXL, the stubbornness of the infection can be more because A, the altered collagen structure is compact and it doesn't allow the drugs to get inside. B, the keratocyte activity is lowered because of keratocyte loss and there is a delay in the rebuilding or the repair. So both of these, the drug doesn't penetrate well and the cornea can't repair itself. So what looks like a small infiltrate can quickly lead to a melt in CXL infections is something that has to be kept in mind. So I will close with this last and favorite slide of mine, which is about a patient, a young girl who was a known case of lichen planus and was on immune suppressive treatment with her rheumatologist. In picture A, you can see that she's developed a bacterial keratitis, which was unrelated to her primary problem. We scraped, we found staph, and we started the treatment according to the sensitivity. And in picture B, you can see the peripheral scarring starting to happen. And then there came a pannus. A pannus is a natural response to the healing of an infection. And then during the active phase of the infection, she did not show any melting. But in picture C, once the pannus came, then the melt started happening, which is quite unusual. Maybe there was a lot of immunity in her blood or what, which made the pannus not a plus point, but a minus point. So we also did a very untraditional thing. We took her up to the OT and recessed the pannus, which you seldom do in an infectious keratitis, and continue the antimicrobial treatment. And in the last picture, you can see that the scarring has started to happen. Goes to show that when there are two etiologies in place, then the course of an infectious keratitis may slightly deviate from the normal. So with that list of differentials, let me close my presentation. Thank you so very much.